Good evening, everyone. At the outset, I would like to thank Dr. Raju and his team for giving me this opportunity. It's a privilege to present my case in front of the who's who in shoulder surgeons in India. Can we have the presentation, please? Presented within 4 hours. Luckily, it was isolated limb injury and all this neurovascular was intact. So this was his radiographs on presentation. And if I could have the ARS, let me go back. 68-year isolated injury.
So the voting is on. Plate osteosynthesis.
Okay, why not conservative? I mean, all meta-analysis tells anything about 60-year-old, 3 and 4 part conservative is as good as operative. I do agree, sir, but there's a huge thing on review of literature, including the profile trial. So profile trial include all 2, 3 and 4 part fractures. True. I want to bring this point out. So profile trial is only if the surgeon he feels both could be included. It's not for those fractures which straight off we can tell that this requires surgery. Very valid point, sir. Thank you. True. Although in profile trial about 80% of the patients were domestic falls, but they even did include 3 and 4 part fractures in relatively younger who were not domestic falls. Right, sir. So that's again a drawback of profile that most of them were domestic falls. Anyway, so we had most of them for plating, if I'm not wrong, very few for this one. So this patient also had this. So now does this change how we treat this patient? Again a plate?
Yes.
Okay. So
anyone?
Any specific things that we need to change if you are contemplating a plate? I mean, it will be difficult to really plate this with a long plate, so we are doing something like a spiral plate, spiral implant.
So these are two fractures in the same bone.
Yes, sir.
Both have different principles.
Okay.
So yes, we can treat them as two independent fractures.
Okay.
And we know where the discussion is heading. So two fractures,
So
one
what would
implant.
your preference be, sir?
Sorry?
What would your preference be?
Yeah, so which is the more crucial injury in this, which can be more disabling in this, are the diaphyseal injuries. So
I
from
beg
a
to disagree, sir.
trauma surgeon's perspective, it's not a matter of you fix one and 3 hours later you can do the other. So which one to fix first? So fixing the diaphysis makes it only a proximal humerus fracture then.
So okay, so what would your plan be, sir? From what I feel, you are planning a plating for the isolated straight plate for the shaft?
Yeah, what I can do in this is use a plate anteriorly on the shaft of the humerus.
Okay.
3 holes above and 3 holes below. A 10-hole plate, 3 holes above, 3 holes below. Just get acceptable alignment for the shaft, and then go ahead and do the plating of the proximal humerus via the delta pectoral approach.
All right. That's one of the way to do it.
So how many will treat this fracture with plating? 2 plates. Of course, I
Depends on
don't think you can do with 1 plate.
So the 1 plate or 2 plate is a separate option.
I feel that it requires 2 plate. Yeah.
Why
not?
Any particular reason?
Okay.
The challenge with 1 plate is you have to expose both the fractures, reduce both of them, and then use one single implant to fix both of them. So that is a little technically challenging. So your attention will get distracted,
So
up or down. So is the simpler one. So fix the simpler fracture first and then do the more complex one. That's my outlook.
As long as we could
Yes.
get reduction here.
Doesn't
Doesn't it depend on the radial nerve status? Because if the radial nerve is gone, then you will have to do a posterior approach.
The chances of radial nerve palsy in such injuries is less than 1%.
Yes. Again, yeah, this patient didn't have, and at least now we are very clear. Even if there is a radial nerve injury, we do not need to go posterior.
You don't need to open it.
We don't need to
See
open.
it.
We don't need to explore.
So-
It's only
so-
in case of an open sharp fracture where the chance of the nerve being cut are high. In a closed fracture with a radial nerve injury, the nerve is always intact. We don't need to go posterior.
So almost, I would say 30% preferred for plating. So rest, I presume they want to treat this fracture by nailing.
Nailing? All right, great.
Only one. Then okay,
Yeah,
orthoplasty.
I'll come to the CT. Yeah, okay, that's the CT.
Okay, so how?
68-year-old patient.
So Dr. Ashish would like to do orthoplasty. Anyone else who wants to do orthoplasty here?
So,
Amit?
uh,
3.
so sorry if I may, arthroplasty means you are planning a long stem all the way? Or is it like, okay.
Okay.
All right. So that's the CT, anatomical neck, 4-part, some impaction there. I mean, it's not working anyway. Let me just, yeah, there, right? Okay. So we have had a discussion about this, and some take us for plasty. Most of them would like to plate. 1 or 2 plate depends on the reduction that you would be able to achieve in trop. And I have a couple of my friends who would like to nail this. So yeah, so it's actually much easier to do it with a nail. Number 1, the distal fracture is out of equation once you plan to nail this. It doesn't matter what type of a fracture it is, as long as you could get in 2 multi-angular screws distal to the distal fracture, it's totally out of equation. Even if it's comminuted, spiral, oblique, doesn't matter at all. So the initial worry that sir had is perfect, that unless we get a good reduction, we can't, it's very difficult to plate because whatever traction we give will not act. But when you are nailing it, it doesn't matter at all, okay? Because the moment nail goes, it more or less aligns it. So just think that it's a proximal humerus fracture. We are putting in long nail, of course, but it's only a proximal humerus 4-part, very easy to tackle with a nail. So get the neck shaft angle right. Transfix it onto the glenoid because this was an anatomical neck, very shallow part of the proximal part of the humerus that we have. So what happens is when we pass a reamer or a nail, high chances it will spin, and that is when it devascularizes. Usually post-trauma, of course, rates of AVN are there, but it's very low. It's the surgery which causes AVN because of our dissection or if we do not take adequate care intraoperatively. So it's very easy to do it if you transfix that, take an entry. See, once again, with the newer generation, we will not bother about the entire reduction as of now. Because
Dr.
most
Shailesh,
things,
this is all open?
Yeah,
Dentopectoral
this is open
approach?
nailing.
Yeah.
This is open.
Open
So
nailing.
for a 3 and a 4-part fracture, nailing is open.
Yes.
It's the reduction is very similar to what we would do with a plate. It's only the mechanical advantage of a nail that we are going
Yeah.
to use. It's not deltopectoral approach.
It's a direct lateral.
It's a anterolateral approach.
Okay.
Anterolateral
Okay.
approach.
Okay.
Right. So once a nail goes in, then we can always pull back the tuberosities to where they belong, and then suture it and pass the sutures through the bolts which are there in the nail. So that's how easy it will be compared to what we're doing with the plate. Plate, many times what we see is we put in the K wires, and then when the time comes to put the plate, one of the K wires will be coming in the way. We need to remove that, and the moment we remove that, we are going to lose the reduction. Happens. This is a multi-lock nail synthesis. So that's for the distal one, it aligns and get into multi-angular bolts distal to the fracture. That's through the range of movements in trop, AP, true AP, and interrotation view. That's his immediate post-op. At 3 months, we were actually concerned that the distal fracture is not uniting. We had told him we will intervene at some stage, but the patient was not very keen. This image actually at 2 years he sent us. He is retired, but is in Gulf. He sent this images, and this was his range of movement at 6 months.
Great. So,
Just to conclude, why? Because if you could actually appreciate the difference, the immediate post-op or X-ray what we get remains the same until union. Now that doesn't happen with the plate. In plate, when there is significant comminution, you see secondary displacements happening. You see some amount of varus drifts happening. Now this might, even a mild amount of varus drift happening will jeopardize the functions of the patient. So that doesn't happen with the nail, proved beyond doubt. So why does that happen? That is exactly because of this, that the plate is trying to hold the head of the humerus on the side, whereas the nail goes through the head of the humerus. So no matter how much the patient loads, the head cannot drift into varus. So message would be that these ones are biochemically much superior. We need to definitely start considering in 3-4 part fractures also. And all the problems that we had with the plate, secondary displacement, screw back outs, screw cut throughs, varus collapses, do not happen with the nail. So we do not need to add any augments like a fibula strut or a medial plate, as long as we do the nail in a good entry and have good multi-angular screw options. Thank you.
Dr. Shailesh, what?
No, it will be the same like what you do with the plate. You get the fiber wire or the bond through the tendon bone junction, pull it back to where it belongs. This particular nail design in the bolts has screw holes, so we could take bites through them and secure it. Of course, we are securing even the tuberous onto each other plus the screw bolts of the nail.
Dr. Shailesh.